Microphone number 2.
Ann Johnson from Syracuse, St. Joe's Family Practice. This is more of a practical question too, and it's about patient privacy. You know, if I'm obviously if I'm going to be checking this, my patients all be above board and make sure and audit my designees and you know, use it as the law is intended and within the bounds of the law. Wouldn't want to risk my license. However, if I'm a patient, I'm a prominent politician like the New York State Academy of Family Practice President Dr. Kaplan, or say I'm Mayor Bloomberg or a New York Yankee, and I'm worried about somebody out in Podunk, a pharmacist or a you know, nurse designee accessing my information. I mean, once that information is accessed, the cat's out of the bag. I mean, there's a lot of patient privacy. How can I audit who's accessing my record and can I be sure that there's state audit of that?
There is state audit of that. You will not be able to access short of some type of lawsuit, and there are very strict limitations on the type of lawsuit or the type of legal proceeding where this information can be accessed. Public Health Law 3371 limits where PMP data can be accessed, and namely it's just criminal prosecutions. This isn't accessible in civil suits. So you won't be able to know who's looked you up and who has not looked you up. You won't have access to that. The department has the duty, which was described in the Supreme Court case, Wayland v. Roe, and which is attended to keeping this data, just common sense as well, to make sure that it's not used inappropriately. When we were talking about this bill, that was a concern that was addressed and brought up numerous times by several legislators. And oddly enough, in the process, they kept mentioning Madonna. And I don't know why, because I would say, well, what's Madonna's real name? And, you know, you can't look her up unless you know her real name. And they then switched it to Andrew Cuomo, and I said, don't do that, please. But there is a duty on the department to make, if all of a sudden there are people searching. Now, it's not foolproof. Someone is going to be able to access the system and unlawfully disseminate it. You can't build a foolproof system. We're trying to put in as many audit trails and as many red flag and warning systems at each and every step as is possible. But you know, one of the things that concerns me and why we wanted to make sure that practitioners could designate and undesignate is, you know, front office staff thinks they're about to get fired. They're going to look up the Yankees and go sell it to TMZ. You know, that's going to be their severance package. And we want to make sure that doesn't happen, so that before you fire them, you take away their permissions and you make sure people don't. So the main burden is on the department. I can't guarantee it will never happen, just cannot, but we're taking every step we can to prevent it from happening.
And can I actually make a comment on that? From a private practice owner, when you have someone who works for you, they sign agreements, disclosures that they won't use any information in an unlawful way, and it's only in the purview of what they're doing for the purpose of their job, not anything more or less. Granted, it's also the word of the person who's doing it, but still, that's, is that me? That's
Heard his name, he's not happy.
that's, I mean, so you're taking that person at word, but at the same time, if you can also limit who's going to be designated, and correct me if I'm wrong. So, for instance, I wouldn't give carte blanche access to all my staff. I would have 1 or 2 designees, and if they are leaving, not leaving, you would change that. So you can limit that in your own practice too, so that you have some control over that. And I've actually had a patient of mine who was working for a local hospital who was actually fired for accessing the information of her child's father's sister when she shouldn't have. So that's within your rights that you can get rid of someone who you find out is doing otherwise. So.
Microphone number 1.
Sam Sandusky, Nassau County. I was wondering if you could talk a little bit about resident physician access to the system and what they will or won't be allowed to do.
So residents, if they don't have a medical license in the state, will be able to access the system the same way that front office staff would be able to access the system. And one of the things that we've done talking to different institutions is to say, look, if you want your residents to be directly accessing this, make them sign up for an HCS account up front. And at some point in the year when the residents first come in, have anyone who is the attending, a precept, anyone who's going to be supervising designate, so that that resident will be the designee of 50 doctors, and they can choose. Or alternatively, just have a dedicated front office staff who's going to be getting these reports and providing them to the residents. We're not saying how to do it, but we're trying to show what the possible solutions are to address residents and, hospitalists and their ability to designate somebody if there was no direct employment contract. There are a number of different issues. The one that we've heard institutions are probably going to use is to have all of their residents sign up for HCS accounts right away and to get them designated by as many practitioners on day one and just keep those permissions until the next year when they rotate in a new class.
Microphone number 2.
Renee Argomano, Albany County. I think this is not really a question, but asking for guidance. I try not to give narcotics as much as possible, but of course there are patients that need, medications, and there are patients that come to our clinic, new patients who are in tons of pain medication, without proper documentation. Now, what am I going to do? Should I, go get all those information first before I give it? Or sometimes I send patients I start the patient for a month maybe, and then send the patient to pain specialist. But it's so difficult, even in the Capital District, to get a pain management that will manage including the medication. The patient will come back, they only want to give me injection, So most of the time you're like,
Well, so in terms of how this law would affect this, and please cut me off if I'm not addressing it. If you're administering, you don't have to check the system, but if that patient shows up and they're in pain and they're a new patient to you, and we actually saw this somewhere in the state where a pain management practice ended abruptly, a number of people didn't have access to care. And if someone showed up on your doorstep and said, I get Oxy 5, I get Oxy 30, I get Duragesic patches, you're going to chase them away. You probably wouldn't prescribe to them until you see the medical record. The new PMP with all prescription data will show you that that patient was on a standard chronic opioid therapy regimen and that they had been seeing one practitioner. It will tell you what they're on and what they're not on. It will be an independently verified source where you can verify or discount what that new patient is telling you. So that's one way where we think the new system will actually protect legitimate patients' access to care.
in addition, right now we're using Hixney, but we know that not all pharmacy actually participate in that. So but this time, all the pharmacy will be participating, correct?
I'm sorry, I didn't hear what you said you used.
I'm sorry. Currently, we're using Hixney, the e-prescribing.
Right.
But unfortunately, not all pharmacy are participate. So, but when this program will start in August, I hope everybody will be.
Well, so the e-prescribing is, the requirement to e-prescribe isn't until March of 2015. There's no law requiring pharmacies to receive e-prescriptions, but if they want to stay in business, they're going to have to get up to speed and receive e-prescriptions. Or if they're only receiving paper, that's probably going to be a red flag. So pharmacies are required to report this information to us now by law, and we receive about 1,700 pharmacies report to us directly, about 4,000 of them use a vendor, and a lot of the institutions will report to us directly. So reporting the PMP data, every pharmacy that dispenses a controlled substance, with the exception of VAs, are required to report to us. There's recently enacted a regulation to allow VAs to report, and we're going to encourage them to participate, and we're talking with them about that. But, so the pharmacies are, for the PDMP, they have to participate. For e-prescribing, the free market's going to drive them to it.
Thank you.
I have a follow-up to her question, actually. It's regarding what she mentioned about pain management, and a lot of them only wanted to do injections. One of the parts of this rule, of this law, is regarding the prescription pain medication awareness work group and continuing education. As an academy, we typically are against mandatory CME, and we prefer that it stays within the realm of our own organization. We think we have a good job of performing that. We're willing to work with organizations to make continuing education that would be beneficial to everybody. So my question is, in the original iteration of the original bill, it was a mandatory CME. Right now, I don't see that it is. So is that going to change? Is it going to be different for different providers, such as pain management specialists who only want to do injections and push their patients to us for pills, or what's going to happen with that?
So the work group, when it comes to the part on making recommendations about mandatory or non-mandatory medical CME and continuing education for pharmacists, I know what they're doing, but I'm not actively participating, mainly because I don't want to be running a work group that's going to make a recommendation to me. There is someone in the audience who is standing at a microphone right now who knows what that work group is doing. It's been a very contentious point of discussion with very strongly held beliefs on both sides. And I do believe their recommendation is coming very shortly. That being said, as an attorney, I've never had a client. I've either been at the DA's office or the Department of Health, but I know more about commingling funds and setting up escrow accounts because enough lawyers have stolen money that it's mandatory for me to take ethics and to learn that. I was surprised to find that pain management is not taught largely in medical schools, that it's not the number of pain management specialists out there. I'm going to forget his name. I think it's Dr. Lowy. He's the head of palliative care at NYU Langone. Had a stat on the number of board-certified pain management specialists. And I don't need to tell anybody that there's a dearth of pain management specialists, but it's shocking when I actually saw the number and how it related to other board certifications. And certainly I think practitioners, family physicians, as well as the general public would benefit if all specialties had a greater awareness of how to manage pain.
We have 10 minutes, so I would just ask whoever is standing, minimum statement, maximum question.
I'll keep my answer short.
Do you want me to give an answer to that last question or not?
You're at the microphone.
Okay, that wasn't what the microphone. The committee is recommending for most providers would have a 2-hour course initially when they apply for your next narcotics license, and every 2 years thereafter, a 2-hour course, or you could do an audit of some of your charts, maybe 10 charts. That's not well defined. But if you prescribe more than 100 milligrams of morphine or its equivalent, which would be like 60 or 70 milligrams of oxycodone or hydrocodone, would be 100 of morphine, that you would need an 8-hour course. And the reasoning behind that is because below 100 milligrams, there's very little. People that want to divert are going to usually get more than 100 milligrams, and most of your overdoses and addictions, it's more than 100. So someone that's on 30, 40 milligrams is not likely to be addicted and probably not diverting. They could be, but anyway, that is and so we thought the 8-hour course. I actually have a question for Reed. I'm had been the liaison from ASAM to the AFP, and we have over 500 physicians in ASAM that are family doctors, a number of them in this room. In fact, I think June is a member of that and a number of others. In any case, over the years, and you're sort of, this is not really fair for you because you are the president-elect, so you're not responsible for the past. But anyway, you still get the question. Our academy has been trying, we wanted more addiction education through the academy. And we took a resolution a number of years ago. Bob Moore was on the education committee then, and they just didn't do anything different. It didn't. And you go to the national meeting, maybe they have one thing in addiction and 7 and 8 on dermatology and so on. And then we took a buprenorphine resolution, trying to get more doctors to prescribe buprenorphine, and asking the academy to put somebody on the national advisory committee at no cost to the academy. And they never did that. There's certain technical reasons why they didn't do that. This is before your time, so you're not responsible. So I didn't know if you had any, some of the other groups like pediatrics has their own addiction committee and internal medicine. and health of the public, really never wanted to address addictions. Vito was on that for a while, and it just, so whether with this epidemic of prescription drug abuse and the connection with addiction and the need for buprenorphine and so on, whether there's any, how you feel, I guess that's all I can ask you. I can't ask you to be responsible for 5 years ago.
I appreciate the recognition that it's not really all my fault, but as Phil, I'm sure, knows, it still is kind of. I think some of the frustrations in the past are very real. Times are different now, and I know as part of our ongoing issue at the national level, we were reviewing educational offerings. And I can't specifically state on addiction, but I have a feeling there has been more offered even at the National Scientific Assembly than there were at the time of those resolutions, but I can't give you exact numbers. I think the most hopeful thing I can say is that at the leadership level, which include the 3 officers, President, Chair, and President-elect, we have already had several meetings this year with high-level folks in President Obama's administration addressing this, including education. So there is a need from top down for us to do more. And there's been a lot of reorganization within the academy, including when Dan Ostergaard retired, Julie Wood is now VP on Public Health. And just before I came out here, she was letting me know of, I'm not sure if it's officially a task force, but she has convened a group that is very actively reviewing aspects of pain medication, opioid education, prescription drug overdose issues, education, et cetera. So in fact, if you'll touch base with me, I'll make sure that you and Julie have connections, because they just had their first meeting about 2 weeks ago, and it looks like a very active group that will directly address a lot of your concerns. I want to make sure you're connected with it.
That's exciting, and we had talked to Julie before. Maybe it's paying off in the long run.
I think it has. I think she remembered because she's taking off and running with her new duties, and this is a priority.
Reed, I just want to make a comment on that. In San Diego at the national meeting, I'm giving 3 sessions on abuse and addiction as plenary speaker, so just to let you know that.
Outstanding.
Microphone number 2.
Thank you. Jason Matuzak, Erie County and on the board. Terry, a quick question for you. I understand, and maybe I missed this, maybe you said, but you said that if you're in a multi-physician practice, that you can link your accounts together, essentially, that you can kind of combine and have multiple DEA numbers listed together for the different providers, I think. And you also indicated that we could all designate, essentially, if we wanted to use a common person that queries this this list, each day, if it was a front office staff you had indicated or something along those lines. Now, what's not clear to me is that, say that you do decide to de-designate that person, do each of the 20 physicians still have to go in individually and de-designate that person, or will the linked accounts be able to designate and de-designate individuals in a group fashion?
So when I talked about combining DEAs, you're allowed to combine your own DEAs. So physicians are not allowed to go in and search somebody else's DEA account and their prior prescribing history, but you can combine your own, and you can, a 20-physician practice can all designate one person. Under the current system, the way it's set up now, yes, you would each have to go in and de-designate that person. If there was, if there was a real fear and an urgency, it's not my bureau that's in charge of the health commerce account, so I can't promise that something would be done in an emergency. The way it's set up, each person would have to go in.
Okay. Thank you.
Microphone number 1.
Hi, Drew Merritt, past president, Syracuse. Comment and a question. Comment, we attempted, taking your advice, we tried to get HCS accounts for our staff and had a significant problem. We kept coming up with the fact that you needed a license to get an account. So I would just ask if you could check with the people that are in charge of that system to get us the information how to get unlicensed personnel an HCS account.
What I'll do is, we have one-pagers on how to sign up if you have a license, how to sign up if you don't have a license. We've also worked with the staff that answer those telephones. I'm going to send to Marcy the one-pagers, and she can disseminate to whoever she wants. They are available on our website as well now, but I unfortunately can't get any of that.
Thank you. The question, what about nights and weekends? When you're not in your office, calling in right now we can call in an emergency supply of controlled substances. I'm questioning also what will happen in the future when all prescriptions have to be electronic. Will we still be able to call in a small supply
Well, there's no exception that says on a night or a weekend you don't have to check. There is an exception for consulting the PDMP, which speaks to the practitioner is unable to access the registry. And I think if you can't access, if someone can't access on your behalf, you can't get a hold of anybody, and it's going to impact the patient's medical condition, that seems like it's reasonably encompassed within that. Again, it's a reasonable standard, and I think what people believe is reasonable and is not reasonable differs widely. Exactly where that line will be drawn, I don't know. That's going to, time and experience, but the regulation and the statute are pretty broad to try to not be overly prescriptive.
But how about the non-controlled prescription? Once we're required to prescribe everything electronically, we'll be able to call in.
The exception was for a 5-day supply if using e-prescribing would somehow negatively affect the patient's medical condition.
Thank you.
Last two questions. Microphone number 2.
Hi, I'm Danny Nagassi from Columbia in New York City. I had a question about HIPAA. It was my understanding that if you're caring for a patient, you can discuss information about that patient with another provider of that patient without the patient's consent. And that's
So,
within HIPAA, but I just wanted to clarify that.
and I am the last person who you should listen to about HIPAA. You should, listen to your counsel, to your supervisors. I just warn you that this is HIPAA-covered information. So even though we can collect it and report it, those are exceptions to HIPAA. It's not exempted material. So it was just a warning that before you start,
Pick you up the
do
phone.
what you do. If
Okay.
it's appropriate, don't let me tell you otherwise. But it is HIPAA-covered information.
Thank you.
Real short. Joe Booth, Oneida County. Can we currently e-prescribe narcotics in New York State? If not, when?
You can now. What the regulation requires is that you use a DEA licensed, a DEA-approved application, and that you let the Bureau of Narcotic Enforcement know that you're using that application. And to that extent, what we've done is we've reached out and had conversations with the application providers who are giving us the list. We just want to know that you're using an appropriate application. There are no security requirements beyond what the DEA
Do you have a
requires.
list of, do you
But
have a
yes,
list of
you can.
approved? Do you have a list of approved applications?
I do not. If you went to SureScripts, they would have a list. I don't want to make it sound like I'm pushing SureScripts, but they tend to have the best repository on e-prescribing applications. There are a number of them out there. The most popular one is Dr. First. They have a few different. There's only one current e-prescribing application that I'm aware of that's incorporated into an EMR off the shelf. You can obviously get someone to do programming for you to incorporate it. But with that said, we were told that we were going to be inundated by one of the very large prescribers with all the applications, and we've received 3. And we had to call the people and ask them to apply to us. So as of right now, there are no providers who have actually given us what application they're using yet. So, but the check is, you just have to provide it to us, that's it, in an email. You can contact us at that email or call the Albany number, and we'll be able to help you out.
Thank you.
One question we haven't touched on is the patient's obligation to be truthful. So if a patient comes in and gives a name and date of birth that is not correct, not accurate, both in the old paper system and in the new system, once had this happen in the practice and had the police come and they didn't know what to charge the patient with. So my question to you is it a crime to impersonate somebody in the process of getting a controlled substance?
The law is even more prescriptive than that. Section 3397 of the Public Health Law says it is against the law to receive a prescription from a practitioner if you already have another prescription for a controlled substance from another practitioner and you didn't tell the prescriber that you have that prescription. It's a section called fraud and deceit, and it's commonly referred to as doctor shopping. It is actually the law. You have to tell your provider that I have a prescription for this controlled. before you receive a prescription from them. And to that end, we actually have posters and pamphlets. You can either print it out off of our website, or we'll send them to you free of charge, which says it's the law and gives the patient's obligation. Violation of that law is an unclassified misdemeanor, punishable by up to a year in jail. But if they actually take receipt of the controlled substance, depending on what it is, it can also be charged under Section 220 of the penal law. And if it's an oxycodone product, that's a B felony, which now, first arrest is punishable between 1 to 9 years determined in state prison.
I would like to thank our panelists. And we have a break, after which we come back for elections. 15-minute break. Thank you very much.
Thank you very much.
Tremendous. Appreciate it. Question offline.